Thanks everyone for joining tonight. I know it's a little late, and hopefully you got all of your kids in bed and stuff. So we're going to start with just talking a little bit about Shockwave, introducing what it is, and going through some of the physics of how it all works, and a few myths and misinformation that might be out there. And we're going to talk about some new exciting therapies that we've come out with through EMS called GDT, guided Doppler class therapy. So we'll go over that as well. So if I go a bit too fast, just write a little comment through to Danny, and she'll let me know to slow down. And if you have any questions, just write them down, and we'll go through them at the end as well. So let's go through everything you wanted to know about shockwave therapy but didn't ask. So let's go through some of the myths. Unfortunately, like a lot of new therapies, there's a few misunderstandings around its capabilities and its functions. So we're going to talk about some of those. Fortunately, during the webinar, we're going to go through some of these facts and help mitigate the spread of these myths, and hopefully get you to share some of your knowledge and the truths about shockwave therapy with your friends and family. So here's one. Here's a myth. Isn't shockwave therapy just a fancy form of ultrasound? The answer is no, it's not just fancy ultrasound. So ultrasound, by definition, is a therapeutic ultrasound. We're talking about, not real-time imaging. Can induce effects not only through heating, but through non-thermal mechanisms, including ultrasonic cavitations, gas body activation, mechanical stress, or other undetermined non-thermal processes. As the energy within the sound wave is passed to the material, it will cause oscillation of the particles in the material, and that basically generates heat. Shockwave uses hang on, whoa, I'm just gonna move that. Shockwave therapy uses shockwaves, which have different physiological properties from ultrasound waves or ultrasound. However, they both utilize mechanical energy, so that's how they're somewhat similar. So another myth is that true shockwave therapy doesn't have to be painful or uncomfortable to work well. The answer to that is no, which isn't always super exciting for the patient. So some compressors can't produce sufficient power to achieve a therapeutic dose, which basically means you have to have a certain amount of energy to produce shock waves that actually do something. Okay, you can make shock waves that are smaller and have less energy, but they don't actually do anything to the tissues that they're used on, so it's kind of useless. So some clinicians that use other brands of shockwave therapy devices say their patients tolerate the machine better. And that's why, because their compressors aren't generating enough power to actually create shock waves that actually do anything. So even though it feels less painful, it's actually not doing anything. So you're kind of wasting your time a bit. So basically, we tell people if it's not uncomfortable to some degree, it usually indicates that it's not reaching that threshold of energy to cause physiological effects on the tissues it's applied to. So if it doesn't hurt at all, usually either you have a crazy pain threshold, or it's just not achieving that minimum threshold. All right, we'll just go through some treatment theories of how shockwave works. So we talked about the red chili pepper effect. So red chili peppers contain capsaicin. At first, this substance overwhelms the C nerve fibers. They're nociceptive fibers responsible for transmitting pain. So, as we all know, with if you eat some like hot peppers, you get that burning sensation in your mouth, But eventually that feels, it leads to like numbness. You can't really feel a whole lot just because it's overstimulated some of those nerve fibers. So the shock waves work in a similar kind of fashion. So when activated, the C nerve fibers release specific substances, which we have here substance P in the tissues and in the spinal cord. This substance is responsible for basically causing pain, you to feel pain during the treatment. However, when you stimulate them for long enough, the fibers run out of substance P, basically, and then you get a decrease in pain sensation. So again, less substance P in the tissue leads to reduced pain. So that's what we're trying to do. We're trying to stimulate those nociceptors, the C pain nerve fibers, to release all their substance P so that it can't cause any more pain. Okay. You get less substance P, also causes so-called neurogenic inflammation decline. So you get a decrease in neurogenic inflammation, and that leads to healing. So here's some references regarding red chili pepper effect. You want to have a look. So origins of shock waves. So here's the atomic bomb that was dropped on Hiroshima during World War II. So shock waves were discovered during World War II. Some soldiers that were in the military were coming back to hospitals and stuff, and they had problems with their lungs, and they discovered that shock waves created by bombs, obviously, like grenades and tank shells and stuff going off near these soldiers, were causing internal damage to their respiratory system. So then they did some research, and they discovered that low energies could have a beneficial, low shockwave energies than lower than bombs and such could have beneficial effects on the body. So originally they developed shockwave for urology with pneumatically generated shockwaves, and they were used mainly in the 90s is when they started using that. And then in 1999, Swiss Dollar Class started doing the extracorporeal shockwave therapy. And over the following years, a growing number of orthopedic indications have been added to the list of treatments that we now use for shockwave. Danny, I can't see you on there. I don't know if your camera's on. There, okay. We going good? Am I going too fast or good?
Perfect state. Perfect.
Okay. So so what is shockwave? What is a shockwave? So we just have some pictures here. That's just lightning. That's a jet plane breaking the sound barrier, and there's a bullet. Again, you can see the shock waves it's creating just because of the velocity it's going at. So in physics, a shock wave is a type of propagating wave that moves faster than the local speed of sound in the medium. So like the thunderstorm, you get the crack of the thunderstorm, or earthquake or supersonic flight, like with the jet. A shockwave is characterized by an abrupt change in pressure, temperature, and the density medium, and by the energy it carries through, which dissipates relatively quickly with distance. So we take something that we found in nature and we've applied it to a therapy. So there's different types of extracorporeal shockwave therapy. So this just breaks it down in the two main ones we're going to talk about today, which is radial shockwave therapy and the focused shockwave therapy. So extracorporeal shockwave therapy has been used to treat many musculoskeletal disorders for the past 30 years. So it's even though we say it's relatively new, it's 30 years is starting to get a bit mainstream, a bit long in the tooth. It's not, you can't really say it's brand new anymore. But for a lot of people, they haven't been exposed to it, so it's new to them. So a shockwave is a single acoustic pressure pulse. It is characterized by rapid rise and peak pressure, followed by rapid drop in the ambient pressure. And we'll go through that in a sec here. The energy promotes repair, regenerative processes of bone, tendons, muscles, and other soft tissues in the body. So here's EMS's, a picture of EMS's newest radio shockwave device that we've just released this year. So let's talk about the radio shockwave therapy. So you can see on the picture here, it comes out in a radial fashion or conical divergent fashion from the applicator, whereas the focus does the opposite. So it comes into a focused pointed area. So the radial is more convex, and as you can see here with the focus, it's more concave. So all the shock waves come into this point here. So how it works. So here we have the handle, and as you can see, there's a projectile inside the handle, and it gets pushed with compressed air, and the projectile hits the applicator here, and that creates shock waves in here, all right? And that can, with this is the 15 millimeter applicator, and with that one, and this is the Evo Blue handle, it can penetrate up to 40 millimeters deep through tissue. Yeah, so that basically just says what I just said. Yeah, so shockwave energy is then emitted through the tip of the applicator and applied to the patient's tissue. You also have to use a gel, kind of like with ultrasound, so you minimize the loss of energy from the skin to air. So you need some gel between the applicator and skin, similar to ultrasound. Just some fundamentals of radial shockwave therapy. As you can see here, again, that's the projectile hits the applicator, and then just go through here. So the first stage, we'll keep going here. So the first part creates the peak pressure, positive pressure here, and then that's followed by a drop into negative pressure. And that's what creates the cavitation bubbles here. And the cavitation bubbles are what we theorize that causes the physiological changes to the tissues that they're applied to. All right, we call that the tensile phase up here in number 2, and that's the compression phase is number 1. We got a little video here. So this is showing the shock waves being generated. So you'll see the 2 phases here. You'll see the compression phase, and then when you see the tensile phase, you'll see the cavitation, little black bubbles will show up here. So hopefully this works. Can you see the video, Danny? Yeah, so the video worked. So you guys, can you see the little specks, the little cavitation bubbles? Danny, yeah?
Perfect.
Yeah,
Perfect.
okay. So we'll just run that video again, just so you get a second chance. So there's the compression phase, and then you get the cavitation bubbles forming there, okay? So that's the magic stuff that causes the physiological changes in the body. Here's me just treating someone with an Achilles tendinopathy. Again, using the Evo Blue handle. I've got a different applicator here, and I got the 36 millimeter applicator here. It just covers a bigger area than the 15 mil. So I'm doing what I call ironing. So I'm moving up and down the Achilles whilst I'm treating it. right. So for those of you who haven't seen Shockwave before, that's a basic treatment. Obviously, it takes a little bit longer than that, but that was just a quick little view of how it works. Okay, we'll talk a little bit about focused shockwave therapy as well. So here's the fundamentals with this. So instead of using compressed air, we use electricity, and it's a piezo ceramic crystals in the handle, and we have a thick gel pad here. And with this one, you actually get the benefit of the focus is really its depth of penetration. So as you can see, instead of with the radial, we got 40 mils of penetration. Here we can get up to 80 mils of penetration. So for some of those deep tissues that are difficult to get to, or if you have a larger patient, it allows you to get to some of those deeper tissues that you wouldn't necessarily be able to get to using the standard radial head. So it's the same premise, though. You get the compression phase followed by the negative pressure tensile phase, and that creates the cavitation bubbles here. So this is what it looks like, the piezoclast from EMS, and so it has all these different settings. So you have the intensity, you have the impulses, number of shock waves that are given. You have the frequency, which is done in hertz, which is cycles per second, and again you have the applicator here. And you can change the thickness of them to either allow for deeper penetration or for less, more shallow penetration with this device. So we're just going to show you some cavitation, the difference between cavitation formation with the different devices. So the bars are, when we talk about bar, that's the pressure, how much pressure. Usually when you look at studies, they have a different measure. It's I believe it's millijoules per millimeter squared. I'll double check that, but it's usually, the way I remember it is like 2 bar is 0.05 millijoules per millimeter. So that's, when you read studies, you'll constantly see that they don't usually put it in bar. So if you want to convert that, it allows you to do that. So anyways, so here's the EMS. That's the Evo head. That's the standard radial head, and we have another applicator handle, rather. It's called the power handle. It allows for a little more energy to be transferred into the tissues. So you can see with that one, it gives us the greatest cavitation bubble formation. And this is some of their other brands. This is a BTL, and here's the Zimmer. You can see very few cavitation bubbles forming in this one, and especially if you look at like the Storts here compared, and the BTL compared to the Evo and the power handle. There's quite a big difference between them. Again, the cavitations are what the theoretical model of how we cause changes in the tissue. So you want more cavitation bubbles equals a greater physiological effect or therapeutic effect. All right, just some indications for shockwave therapy. So there's quite a few. So we can use it on trigger points. It's actually really effective for trigger points. I do that quite a bit on patients. I used to do like compression, like Nemo's release on patients. And when I first got the Shockwave device, probably about 5-6 years ago, I started using it on the trigger points and compared it. And some of my patients noticed that they got way longer relief when I used the Shockwave versus just doing the standard manual compression. which was interesting. It saves my thumbs as well. So that's another good point. Lymphedema. So we've had nurses come to other seminars that I've presented, and they're quite interested in lymphedema for working with patients with that condition. So you got all the tendinopathies. There's research for Osgood-Schlatter's disease. Again, wound healing. It helps with wound healing. And cellulite, it's actually been shown to be beneficial for that. And Peyronie's disease, which if you're not familiar with, it's a curvature and the male erection. It can be quite painful due to scar tissue formation in there, and so it helps. It generally helps with the pain. Doesn't always change the appearance. All right, so here's some more indications. Again, we have trigger points, tension headaches, osteoarthritis. So it's been shown to cause physiological changes in our arthritic joints. So it causes new cartilage formation, and again, we get the decrease in the substance P, so you get an automatic or instantaneous analgesic effect. They've done some studies actually in China on spasticity in infants, which is pretty interesting. Again, we have all the tendinopathies, which it's very effective at treating. Osgood-Schlatter's, acute and chronic tissue wounds, lymphedema, and fracture non-unions. It's actually, there's quite some quite good evidence showing that. Particularly for like the femur, that can be quite difficult for some surgeons to repair or work with. They can use shockwave to actually stimulate the osteoblasts to proliferate and cause that fracture to heal much better. So some emerging indications, we have persisting pain after partial or total joint replacement and painful neuropathies. All right, some contraindications for shockwave therapy. There are a few. We'll go through them. So we don't want to treat over air-filled tissues. Again, as we talked about in the origins, shockwaves can irritate and damage lung tissue. So we try and avoid going over those areas. Treatment of pre-ruptured tendons, treatment of pregnant women, treatment of patients under 18, except for Osgood-Schlatter's, treatment of patients with blood clotting disorders, including local thrombosis, treatment of patients that are on oral anticoagulants, treatment of tissue with local tumor or local bacterial viral infection, and treatment of patients treated with cortisone. However, you can treat them if you allow a 6-week period between when they had the injection and when you administer the treatment. So I put this here as relative contraindications. So for pregnant women, I myself choose to treat them if I'm doing something like a plantar fasciopathy or a tennis elbow. Now that's up to my personal clinical judgment. There are no studies showing that shockwave is actually harmful to pregnant women. However, there are no studies showing its safety. So it's really up to the clinician if they want to do that. I myself choose to do it, but that's up to the individual practitioner. But we still say it's a contraindication. And for patients under 18, I usually, I've treated a few patients under 18. However, I get their parental consent and had good results with the few under 18 juveniles I've treated. Just going through some clinical evidence. So if you're not sure what Pedro is, it's a freely available database that was started at the George Institute here in Sydney. The goal is to provide best insights into the scope of evidence that can be used to guide decisions about the effect of therapy. Pedro database is unique in that it offers independent assessment of the quality of the RCTs it indexes. So that's a really cool thing about Pedro from some of these other online databases, is that they actually rank the study for you. So they use something called the Delphi score. So 0 being the lowest score, 10 being a perfect, like the study couldn't be done any better. So when we look at Pedro for the evidence for shockwave therapy, this is just a little bit of a few of the studies we pulled out, but you can see the ones that are in red here, they're all done with the Swiss dollar class. All right, so unfortunately, some of the other competitors, when they talk about the effects of shockwave, they actually use our studies, or the studies done with the Swiss dollar class. So as you can see here, most of the studies tend to be done with the Swiss dollar class. So, and if you look at the Pedro score here, the Delphi score, we have some quite high scores, like 9s. There's an 8, 2 8s and 9s in here. Okay, so like Achilles tendinopathy, there's 3 of them with 8s. Plantar fasciopathy, a few 9s here. And I have a few of these studies that we're going to go over. So this is what I was talking about, the energy density. Instead of bar, they measure it in energy density flux, which is, as I said, 2 bar equals 0.05 ED, if you want to convert that. So, talking about the efficiency and safety of extracorporeal shockwave therapy, here's a systematic review done in 2015 by Cesar and Christoph Schmitz, who works for EMS. Now, they found that 88.5% of all RCTs on radial shockwave and 81.5% RCTs done with focused shockwave found on Pedro had positive outcomes. So, so that's pretty huge. Those are pretty huge numbers. There's very few other therapies that I'm aware of that have numbers and up that high. Also, we got from the study that focused shock waves do not provide better results than radial shock wave. Applying sufficient energy to the tissue can affect the results. So that's what we talked about. You need to get a certain amount of energy into the tissues to get those physiological changes we're after. 2 studies demonstrate that application of local anesthesia in the area of treatment adversely affected the outcome. So that's where we're talking about, like with cortisone, you don't want to do it within the first 6 weeks, because then the patient might have some analgesia in there, and then that can negatively affect the results. Because when we treat people, we actually ask them for their pain rating. I usually tell people it should be no more than a 7 out of 10. All right, and we want them, the higher the pressure, usually the better result. So I tell people, let me know if it becomes too much. And if it goes more than a 7, I tend to bring it down so they can tolerate it. Okay. So optimum treatment protocol for shockwave appears to be about three treatments at a 1 week interval with 2,000 pulses per session. And again, so that's the highest EFD, which is the energy flux density, or the bar pressure, which you talked about. And with the devices, they go up to 4 bar. All right. Long-term effects. Radial shockwave therapy is safe and effective in the treatment of chronic recalcitrant plantar fasciitis, results of a confirmatory randomized placebo-controlled multi-center study. So this was a 2008 study. The conclusion was that the double class is proven to be efficiently treat plantar fasciitis or plantar fasciopathy and significantly relieve pain in the short term. And here it showed a change of 72% decrease in pain, and even greater. This is at 3 months and this is at 12 months. So you can see versus a sham therapy, which is the red, there's a significant difference between the sham and the shockwave group. Important placebo effect has been observed. However, treatment is better than placebo, which we show here. And again, the study showed that shockwave should be considered before looking at surgery for patients with plantar fasciopathy. More efficient when combined. So this study looked at, so we tried to look at not just using shockwave on its own, but using it with combined therapies. So here's a study that we liked where it talked about eccentric loading versus eccentric plus shockwave for mid-portion Achilles tendinopathy. And that's a 2009 study. So that's ROMP. That was one of the, I think it was a 9 on the Delphi score. So the combination of the Swiss dollar class treatment and eccentric loading had significantly better clinical outcomes than eccentric loading alone. So you can see here, the blue is the radial shockwave plus eccentric loading, and the red is the eccentric loading by itself. So here's one where they added stretching. So they did shockwave with stretching to look at plantar heel pain. Oops. So 152 patients were divided into 2 groups, receiving 3 sessions of radial shockwave or radial shockwave combined with 8-week plantar fascia specific training program or a stretching program. And the conclusion was combination of Swiss dollar class treatment and stretching exercises has significantly better clinical outcome than stretching exercises alone. So again, we can see here in the blue is the shockwave plus stretching, and then the red is just a shockwave by itself. So we can see at 2 months, 4 months, and 24 months that you get a superior effect with the combined therapies. So we promote that. I do it with my patients. I always recommend like eccentrics or some form of rehabilitation, not just the shockwave by itself. Here we're comparing shockwave versus cortisone injections. So in this study, 2016 study, 40 patients with plantar fasciopathy were divided into 2 groups. So group 1 had 5 sessions of radial shockwave therapy, 2,000 shocks. And again, that's the millijoules per millimeter squared, which is the energy density flux. And the group 2 had a single injection of cortisone. And so they looked at pain in the morning and during the day based on the VAS and functional ability using the foot function index. So the conclusion was both interventions caused an improvement in pain and functional ability at 2 months after the treatment, but the Swiss dollar class treatment had better analgesic effect than the corticoid injection, and patients were more satisfied with the radial shockwave. One thing it doesn't talk about is if you've ever had a patient that's had a cortisone injection into their heel, it hurts a lot. So if you can avoid getting a cortisone injection and experiencing that excruciating pain, and just do it with radial shockwave where we can control the intensity, I think that's pretty awesome. So again, here, one of the outcomes was radio shockwave therapy treatment is preferred to cortisone injection, requires a period of rest after it. So again, the cortisone requires a period of rest after it's injected, while the radio shockwave, you can walk out of the treatment room on the same day. It's important to note that steroids, mainly multiple injections, may cause rare complications such as plantar fascia rupture and nerve injury secondary to injection. I saw a few studies in that it can be up to about 10% of patients who get injections, and obviously the risk increases with the more injections they have. So talking about osteoarthritis and the effects of shockwave on osteoarthritis, which is interesting because loads of people suffer from this condition. So this study done in 2013 had 70 patients with osteoarthritis divided into two groups. First group had shockwave. Second group had a placebo. Pain reduction based on VAS and disability were evaluated. Conclusion was treatment with the Swiss dollar class, that's using the power handle, which is the red handle, which penetrates a little bit deeper and is a little more powerful than the blue Evo handle, is effective in reducing pain and improving knee function, at least during 3 months after the beginning of treatment. So again, if you look over at the chart here, we see the shockwave having a greater effect than the placebo group at all follow-up at 1 week, 4 weeks, and 12 weeks. All right, so we want to talk to you about a new exciting protocol we've come up with this year. It's the guided dollar class therapy, or what we call GDT. So what this is basically is we've come up with this comprehensive program that really covers all aspects of treatment and therapy that we do and that we recommend to get patients the best possible outcomes. And so with stage 1, we talk about assessing and engaging with the patient. And stage 2, we have a high-powered laser that we use, which helps with it can give you quite rapid analgesic effects, and it's actually totally pain-free. And then so once we do the laser, we can. So the idea here is if someone's their pain is too great to tolerate the shockwave, is we can use the laser to actually desensitize the tissue, and which then allows us to use the shockwave therapy and get in and cause those physiological changes that we want on the tissues. So then we get in there with either the radial shockwaves or the focus shockwaves. Then again, as I talked about and we showed with the research, we want to do combined therapies such as rehabilitation, and then we do some follow-up to do some objective measures to see how the patient is progressing. So this is quite a complex slide here. We'll just quickly go over it. So this is the high-powered laser that we have with our GDT protocol. The cool thing with it is one of the protocols that it comes with it only takes 3 minutes, so it's a really quick treatment. And we use as I'm sure a lot of you are aware of, there's different wavelengths with lasers. A lot of the research shows that the 905 nanometer wavelength, it tends to be the most therapeutic wavelength available. So they use that in the laser that we use. And usually we recommend in our protocol that you wait about at least 5 minutes after the laser treatment before you start using the shockwave. And the main reason is because we want the tissues and the physiology to get that adaptation that we've caused by using the therapy. If you use it before then, you're not going to get the maximum benefit. So you can wait a minimum of 5 minutes or up to an hour. Obviously, the longer you wait, the greater the effect of the laser will be. However, we recognize that, if you only have, like, say, a 10 or 15-minute appointment with your patient, you can't really wait an hour before doing the shockwave. So say you have a 15-minute appointment, you do a 5 minutes of, 3-minute treatment, and then you wait 5 minutes, and then you can do the treatment with the radio and or focus shockwave. Yeah. So GDT, we talk about the 6 steps again. So we want to assess your patient and their pathology, come up with key questions and tests, engage your patient with treatment plan and outcomes. And then we have using the high-powered laser, we want to treat with the laser to reduce inflammation, pain of the pathology. Then we use either the radial shockwave or the focus shockwave to treat the specific condition. And then we work on doing rehabilitation exercises and protocols to complement the other therapies and increase the recovery. And then at the end, we want to evaluate the therapy efficiency and plan for the next step. So again, we like to do some objective measures there so that we can see if what we're doing is effective or change it to make it more effective. So again, with our therapies, we can quickly and safely treat about 90% of musculoskeletal disorders, which is pretty much all of them. 90% is pretty good. There aren't too many conditions musculoskeletal conditions that we can't treat with these therapies. So as we say, it's a game changer. We think it's gonna make some big differences in patients' lives, and we hope you have a look into it or engage with us to find out more about it. Here we go. So just talking about the role in contemporary clinic practice of using these devices. So basically the landscape of allied health is moving to a new paradigm. Doctors and insurers they're demanding more validated, safe, and effective forms of treatment. And as an allied health practitioners, it's important that we stay current with new and emerging treatment modalities such as shockwave and laser. Otherwise, you risk falling out of favor with healthcare systems, private health funds, and insurance companies. Even greater risk of becoming antiquated as a health professional, which I'm sure none of us want to do. So in order to stay relevant and provide your clients with the best possible therapies available, it behooves you to learn and adopt some of these new therapies. It's my strong belief that in the future, insurers and private health funds will only pay practitioners who can provide objectively show improvements in benefits for their patients. So it won't be anymore that you go, oh yeah, they're getting better. You'll have to show objectively through measures that you are causing improvements. And if you don't, they're simply just not going to pay. So all right, so we have a face-to-face seminar coming up at the end of March. It's on Saturday the 27th in Alexandria. It starts at 1 and goes till 5 p.m. If you want to register, just go to the website down below. We'll be going more in depth with some of the explanations and physics, and we do quite a bit of hands-on on treatment to show you, and so you can experience. I bring up people who've never had it before, so you can experience what it's like, and so you can have a go with it as a practitioner and see what it's all about. So I highly recommend looking into that and signing up. I'd be happy to meet you in person and talk a little bit more about this stuff. You can also go to the Swiss Dollar Class Academy online. There's the website if you want to check that out. We have lots of useful blogs and videos, and we also have, I think we have quite a few studies, full text studies that you can get on there as well, which is always good. That's it. Hopefully I haven't put too many of you to sleep, and
Not at all. Not at all.
there we go. We got through it. All right. Hopefully we can go through some questions now, and hopefully I have some good answers.
Thanks so much. No, it was very enjoyable. Thank you. I'm just looking because we're obviously on Facebook and on Zoom, just seeing if there's any questions. So far, there's not. So that means you've covered off everything, and all those myths are dispelled.
That can be a good thing or a bad thing.
That's a very good thing.
But we'll say good thing. We'll go with good thing.
I agree. But if anyone has any questions, please don't hesitate to write on our Facebook page or send us an email, and we will be happy to respond. So thank you so much, Adam. Always love having you on our webinars, face-to-face courses soon, and our Facebook Live. So we look forward to the next one.
Thanks, guys. Have a good night.
Thank you.